Women's health insurance programs. Health insurance coverage is a critical factor in making healthcare affordable and accessible to women. Among the 98 million women ages 19 to 64 residing in the U.S., most had some form of coverage in 2015. However, gaps in private sector and publicly funded programs left a little over 1 in 10 women uninsured. One of the Affordable Care Act's, ACA's, primary goals was to expand access to insurance coverage and to reduce the number of uninsured. The law requires that nearly everyone carry health insurance, and expands access to coverage through a combination of Medicaid expansions, private insurance reforms, and premium tax credits. This fact sheet reviews major sources of coverage for women residing in the U.S. in 2015, and discusses the changes and impact of the ACA on women's coverage. Sources of health insurance coverage. Employer-sponsored insurance. Approximately 57.5 million women ages 1964, 59%, received their health coverage from their own or their spouse's employer in 2015, Figure 1. Women are less likely than men to be insured through their own job, 35% versus 44% respectively, and more likely to be covered as a dependent, 24% versus 16%. 1. Figure 1, Women's Health Insurance Coverage, 2016. Figure 1, Women's Health Insurance Coverage, 2016. Women in families with at least one full-time worker are more likely to have job-based coverage, 68%, than women in families with only part-time workers, 31%, or without any workers, 15%. 2. Because women are more likely than men to be covered as dependents, a woman is at greater risk of losing her insurance if she becomes widowed or divorced, her spouse loses a job, or her spouse's employer drops family coverage or increases premium and out-of-pocket costs to affordable levels. The AC also requires employer plans that offer dependent coverage to give workers the option of keeping adult children up to age 26 enrolled as dependents. An estimated 39% of women between the ages of 19 and 25 are covered as dependents under a parent's or a spouse's plan. 3. In 2016, annual insurance premiums for employer-sponsored insurance averaged $6,435 for individuals and $18,142 for families, increasing by 58% over the last decade. On average, workers paid 18% of premiums for individual coverage and 30% for family coverage, with the employers picking up the balance. 4. Non-group insurance. The ACA expanded access to the non-group or individually purchased insurance market by offering premium tax credits to help individuals purchase coverage in state-based health insurance marketplaces. It also included many insurance reforms to alleviate some of the long-standing barriers to coverage in the non-group insurance market, many disproportionately affecting women. In 2015, about 9% of non-elderly adult women, approximately 8.8 million women, purchased insurance on their own. 5. This includes women who purchased private policies from the ACA marketplace in their state, as well as from private insurers that operate outside of marketplaces. Individuals who seek insurance policies in their state's marketplace may qualify for assistance with the costs of coverage. Those with incomes below 400% of the FPL can qualify for assistance in the form of federal tax credits which lower costs of premiums, and those with income below 250% FPL can purchase coverage that limits cost-sharing requirements. In a national survey conducted in fall 2014, nearly all, 94%, women in marketplace plans had household incomes below 400% FPL, the upper limit for premium credits, and 75% had incomes below 250% FPL, the threshold for cost-sharing reductions. 6. The ACA set new standards for all individually purchased plans, including new plans available through the marketplace as well as those that existed prior to the ACA. Historically, insurance carriers selling plans on the individual insurance market adopted policies that specifically placed women at a disadvantage, either by charging them higher premiums than men for the same level of coverage, a practice called gender rating, or disqualifying them for coverage because they had certain pre-existing medical conditions, including pregnancy. The ACA bars plans from instituting these policies. Many of the pre-ACA individually purchased policies did not include coverage for services that are important to women, such as maternity care, prescription medications, or treatment for mental health conditions such as depression. As a result of the ACA, all direct purchase plans also must cover certain essential health benefits, EHBs, that fall under 10 different categories, including maternity and newborn care, mental health, and preventive care. Medicaid. The state federal program for low-income individuals, Medicaid, covered 17% of non-elderly adult women in 2015. Historically, to qualify for Medicaid, women had to have very low incomes and be in one of Medicaid's eligibility categories: pregnant, mothers of children 18 and younger, disabled, or over 65. Women who didn't fall into these categories typically were not eligible regardless of how poor they were. The ACA allowed states to eliminate these categorical requirements and broaden Medicaid eligibility to most individuals with incomes less than 138% of the federal poverty level, FPL, regardless of their family or disability status or age, effective January 2014. However, not all states have taken up this option, as is discussed further below. Among all sources of coverage, Medicaid disproportionately carries the weight of covering the poorest and sickest population of women. Approximately 66% of non-elderly women with Medicaid had incomes below 200% of the FPL. More than 1 in 4, 27%, women covered by Medicaid rate their own health as fair or poor, compared to 6% of women covered by employer-sponsored insurance and 11% of uninsured women. 7. Medicaid finances nearly half of all births in the U.S. 8 accounts for 75% of all publicly funded family planning services, 9.5, 51%, of all long-term care spending, which is critical for many frail elderly women. 10. Over half of the states, 28 states, have established programs that use Medicaid funds to cover the costs of family planning services for low-income women, and most states have limited-scope Medicaid programs to pay for breast and cervical cancer treatment for certain low-income uninsured women. 11. Uninsured women. Approximately 11% of women ages 19 to 64, approximately 11.2 million women, were uninsured in 2015, a decline from a rate of 17% in 2013. Uninsured women often have inadequate access to care, get a lower standard of care when they are in the health system, and have poorer health outcomes. 12 Compared to women with insurance, uninsured women have lower use of important preventive services such as mammograms and Pap tests and are more likely to forego medical services due to cost. 13 In a survey conducted in fall 2014, uninsured women were less likely to have a regular source of care compared to women with any form of insurance. 14. Profile of uninsured. Low-income women, women of color, and immigrant women are at greater risk of being uninsured, Figure 2. Single mothers are more likely to be uninsured, 16%, than women in two-parent households, 9%. The majority of uninsured women live in a household where someone is working, 68% are in families with at least one adult working full-time, and 82% are in families with at least one part-time or full-time worker. 15. There is considerable state-level variation in uninsured rates across the nation, ranging from 21% of women in Texas to 4% of women in Washington, D.C. Table 1.